Hello, and welcome back to the White Noise Podcast. I'm Mohan Dutt. Joining me are Doctors Jon Barkham and Alok Sachdeva. This is episode 6, and we are going to be discussing ADHD and sleep in children with our special guest, Dr. Barbara Felt. Alok, you want to give a little introduction?
Yes. Thank you, Mohan. We have the honor today of having with us Dr. Barbara Felt, who is works in the pediatric sleep clinic at Mott Children's Hospital. Dr. Felt trained in medicine at Wayne State University in Detroit, Michigan, then completing her residency in pediatrics at Johns Hopkins University in Baltimore, subsequently completing a fellowship in developmental behavioral pediatrics at the Great Rainbow Hospital in Cleveland, Ohio. Welcome, Dr. Felt.
Thank you very much.
All right. Well, thanks for joining us, Barbara. And before we get started, we'd like to get to know you a little bit. So tell us a little bit about yourself, maybe a one-liner, stuff that you like to do outside of medicine.
So the thing I really miss is music, because when I was at Wayne State for undergrad and then medical school, I was in the marching band, played piccolo, flute, and I was a majorette. So I miss that a lot.
Very cool.
That's very cool.
Yeah. Did you have a favorite type of music to play? Mainly marches?
Mainly marches.
So you were on the field. Does Wayne State have a football team?
They did. And I think they still do.
Oh.
Yeah. Yeah. They didn't win much, but
Yeah, that's okay. We haven't been that great either.
Not this year.
So
Not noteworthy.
not well. I mean, we are 4-1 or 3-1, but
You got a good record.
Yeah. But okay. Anyways, we won't talk about that. I could lament our football team for days. What is the best piece of advice anyone has ever given you or that you've ever received?
So I think really just to kind of take a breath and pause and kind of be where you are in the moment, which is particularly hard, I think, with the fast pace of medicine and increasing demands. But with work with children, I found that really helpful just to like take a breath, step back, whether I'm in clinic or in my other life.
All right. Thank you. And this is our fun question. What's your favorite thing of the month or of your life? Favorite book, movie, TV show, anything like that?
So I actually have two things. So John would know this because we were both up at the sleep meeting, and I drove up that morning to Traverse City from here in Ann Arbor, and just being up there near water, I love water. So that was really great. Yeah.
It was a pretty conference, so.
Yeah, it was a nice setting. And then my other favorite thing is my grandson, who's like 8 months old, and he's really cool.
Nice.
Nice. I'm from Minnesota, so I grew up on the lake. So it's quite nice to do all the fishing and all that.
You don't sound like someone with a Minnesota accent, though.
Oh, don't you know?
Oh, there we go.
Yeah. It's there.
Minnesota.
All right. Do any of you guys have picks of the month?
I got stuck in, hooked on the Cobra Kai YouTube series.
You did?
It's really good.
Yeah?
I definitely did some like binge watching of 2 seasons last week, so I do recommend it.
Billy Zabka. Right?
Is that
yeah, it's the guy from the evil guy from
That's Daniel-san's nemesis.
Daniel-san's nemesis.
Yeah, is it Johnny? I think his name is.
Yeah.
Right?
Johnny.
Yeah, so
I've heard a lot about it. Actually,
it's good. Actually, yeah, it's fun.
It's on YouTube. You have to pay for it.
I got a free trial, so I was like, whatever.
I'll have to. Yeah, I've been meaning to check that out.
Season 3, delay it till December because season 3 comes out in 2020. So you may want to delay your free trial so you don't have to pay for it.
Okay.
Let's be honest, people. Nobody pays for content.
I'm going to check that out.
Except for the white noise content.
No one pays for that.
Oh, wait.
Either. It's free.
I'm joking. So. I'm just messing around. We'll edit that out.
My pick of the month is I'm just now discovering very late On Being with Krista Tippett. Like an amazing podcast everyone should check out. And goes along with Barb's, step back, take a moment. That's really the theme of On Being.
What's it on iTunes?
You can find it on iTunes, I'm sure. Probably most places where podcasts live.
Okay.
Yeah, really good.
All right. And my pick of the month is The Expanse, which is a TV series it was on Sci-Fi Network. Now it will be on Amazon Prime, but it's based off a book series called The Expanse by James S.A. Corey. And it's an 8-part book series. So I've read the books and watched the TV show. It's really good. It's about stuff in space, sci-fi drama. It's funny. It's good.
I've seen a few episodes. It's good.
It's really
I
good.
liked it.
Underrated. It flew under the radar, but it's really quite good. So definitely check it out. All right. Anyone want to get us started with the case?
Sure, I'll start it out if that's okay.
Yeah.
All right. Tim Farbaugh is Tim Farbaugh is an overweight 8-year-old boy with ADHD who presents to your clinic accompanied by his mother. His mother reports that Tim hasn't slept well since he was 5 years old. Specifically, Tim has difficulty falling asleep at 9 p.m. when his siblings fall asleep. He seems anxious at bedtime and often forgets to select his beige khakis and maize and blue polo shirt for the morning. When she has watched him sleep, Tim's mother has noticed that he is very restless. Tim seems slow to get going in the morning and is having difficulty keeping up with his coursework at school.
All right.
So we, as a starting point, keeping it kind of broad, Barb, can you comment on sleep problems in general that you see commonly in children with ADHD?
Sure. The problems are really broad and can involve problems with sleep breathing and restless sleep, other disruptions of sleep, including sleep-wake cycle disturbances. But the real tricky thing with kids with ADHD is that sleep and ADHD, what comes first? It can be really sort of a bidirectional, tricky presentation to try to sort out. And so I work in the sleep clinic, but I also work in a developmental behavioral clinic where I see children who are coming in for their ADHD. And so asking about sleep is really an important piece of the puzzle. Sleep problems are really common in kids with ADHD. Some people will say up to 70%, and they can include behavior problems and medical problems. So I'll hear kids and studies suggest that kids will have more bedtime resistance, night waking, sleep onset difficulties, difficulty with getting up in the morning, daytime sleepiness, and then again, sleep-related breathing problems. People will also kind of mention a lot of nocturnal activity like restlessness prior to bed, restlessness during sleep, and maybe some parasomnias too. But it just is tricky because the families will come in with one problem and you can kind of go down one road, but kind of miss the whole picture of this child presenting with ADHD and sleep problems. And it's really important to ask sufficient questions about both things.
Mm-hmm. Now, if I have a child with ADHD and I notice they have difficulty sleeping, I make note that they sleep less than my other child who does not have ADHD on average. However, the next day, my child's still so seemingly energetic, and I sometimes have a hard time behaviorally kind of reining that child in. And I think to myself, maybe he just doesn't need as much sleep. Maybe that's just how he's wired. Is there credence to that? Does it require more digging to kind of see what's going on? Or
yeah, I think asking about the sleep-wake pattern and whether that child is getting up, is staying up late and then kind of bucking up against an early school start time, that may be limiting their amount of sleep. And asking about sort of sleep cycle patterns on weekends and the summer can give you an idea of what that child's normal sleep is. But studies really suggest that, and sometimes it is related to the type of ADHD, but that's in general, kids with ADHD may present with reduced sleep, but it may really be driven by this later bedtime and then, sort of their need to get up in the morning. And then kids just don't present like adults who are when they're tired. Adults will be maybe sluggish and sort of hard and slow moving, but kids really, especially latency age kids, can really appear more hyper and irritable when they're tired. And so that's what makes it, again, kind of tricky to sort out. And so asking about sleep wake pattern and whether the summer kind of gives you a clue if the child's really getting less sleep than they need, that might be a help. Yeah.
Are you seeing people like present with, children that have inadequate sleep in general presenting with ADHD that's just totally due to not enough sleep?
Yeah, I think that may be true for some, but it usually is a more complex picture. And so I would say typically the kids that I see that are presenting with ADHD, if we maximize their sleep for a percentage, maybe they can go off medication. But more often it's needing less medication than they would if the sleep and ADHD symptoms together were suboptimally treated.
What percentage of would you say, just ballpark?
Oh, I would say it's probably less than 10% of the kids that I see, and this is not from a study.
Sure.
Once you maximize their sleep, their ADHD is completely taken care of.
So it's more like you have better control of it, as opposed to it's not going to be curative, but it's going to be that you have better control, kind of similar to like hypertension or something that you're going to maybe get off some medication or
need less.
Yeah. Do you feel like everyone who presents with ADHD or ADHD-like symptoms, because is it really ADHD if it's sleep driven, if it's due to poor sleep, is it really ADHD then?
Right. Can you diagnose it?
Would you diagnose it as ADHD or is it a different diagnosis?
I would propose that ADHD is a behavioral diagnosis. It's a set of symptoms. And part of the fun thing of evaluating it is to figure out what's behind that set of behaviors that you see. And so for inattentive type, the distractibility and poor ability to organize, being forgetful, or hyperactive impulsive type where kids are blurting out or having trouble sitting still or running around when it's not appropriate, or combined type when both features are there. That is the face of ADHD, but what's behind it can be a myriad of things. So it could be a medical issue like a sleep disorder where, individuals with sleep disordered breathing may be more likely to present with ADHD symptoms. People with restless sleep and periodic limb movement disorder and RLS are more likely to present like an ADHD hyperactive impulsive subtype. But other things can look like this too, right? And that could include an individual with a learning disability with a poor fit with their classroom. Could be a kid with anxiety disorder who's presenting with ADHD-like symptoms. It could be a kid with sleep deprivation presenting with ADHD symptoms. So I think that what makes this work really, I think, really interesting to do is to have an eye on all of that because it could be a sleep disorder. It could be one of these other disorders or all of that together. And then I think what I also find interesting in working with parents is that a lot of the reporting is coming through the parent. And then the parent, since ADHD is highly genetic, may not be the best reporter, may be missing things, or is their home life unstructured? And so that this child's difficulties that they're presenting with may be in part exacerbated by the home environment or trauma or other a pain. I've had kids with severe constipation present for ADHD symptoms. And it's there once you take care of that pain associated with their impactions and stuff. So I think, again, my basic sort of approach is to take a really broad look at the child and to consider all of that.
Now, we're fortunate, the parents around Ann Arbor, this part of Michigan, are fortunate to have your expertise should they need to seek your counsel. However, in other parts of the country that have less robust healthcare systems or maybe are less well populated, or for some reason people like you aren't there, what should those parents do if they, if they think there might be a sleep problem, but there's also clearly a behavioral problem? Do they seek help from the general pediatrician and then use that doctor's guidance in terms of getting subspecialty sleep care? Or what do you recommend?
Right. It can be really tricky. I think here we spend a lot of our educational effort to inform and train our pediatric residents and med-peds residents, family medicine residents in the diagnosis of ADHD and the importance of including screen for sleep problems.
Uh-huh.
And other developmental behavioral pediatricians have devised simple sleep scales like the BEARS, looking at bedtime problems, arousals during the night, excessive daytime sleepiness, and the regularity and rhythm of sleep, and snoring, to be able to make it easy for primary care providers to screen for sleep. However, many primary care providers don't have that training, which is why I think that sleep medicine people are in such a fantastic position to be able to provide that education whenever they can, reaching out to conferences for state pediatric associations, family medicine associations, reaching locally to PTAs to educate the families and things like that. Okay, so your question was really what to do though in an under-resourced area.
Yep.
And I think as a parent, if I had a concern, I would say that parents, they may have a concern about a behavior problem with their child, but they may not really know what to do with that. And I think being persistent to get to an answer, whether it's going to another provider, if that parent isn't feeling like the answers are sort of informative enough. I'm not sure all parents are going to really know which next step to take and are really relying on the primary care provider to do that.
Yeah.
But we do have good resources like the National Sleep Foundation that can provide, good. And then there are some specific sleep online resources now that the parents have easier access to information. So if a parent had that, was informed in that way, then asking for a referral on if the parent isn't feeling like they're getting adequate advice from the primary care pediatrician, I think would be essential.
Right.
And an unfortunate thing is there aren't too many people like DBPs or developmental behavioral pediatricians in the whole country. There's like less than 700 in the whole country.
Wow.
Yep. And so that's why education to the growing sort of primary care providers is so crucial. And then sleep screens like the BEARS can be really a good start, I think.
Do you, I guess, because maybe kids aren't probably the best or the most reliable source of, because I mean, in general, we're not very good. We're not very reliable at kind of estimating how much we sleep. And then, so if they're not that reliable, parents aren't, they're not sleeping, or hopefully at, by the age of 8, they're not in the same bedroom as the child is. So they're not really witnessing any snoring. And we know that children may not always present with snoring or anything. So we don't really know kind of what's going on a lot of the times in terms of sleep. Would you recommend, or do you personally, everyone that you're kind of seeing as a new patient and with, suspicion for ADHD, are you getting a sleep evaluation, or are you doing a screen and then kind of going based on that, or based on the physical exam? Or is it kind of just, you're presenting with behavioral problems during the day? Are you going to get a sleep study and rule out any sleep disorder?
Yeah, such a good question. I'd say in our clinic, in the clinics that I do, or the clinics I do with the psychologist who also works in the sleep clinic, we have like a really low threshold for referring, because we're asking more fine-tuned questions about sleep disorder breathing symptoms than just, are you snoring or not, like on the BEARS. But I don't refer everybody. Okay. And so if an individual is coming in with pretty straightforward ADHD symptoms, and we have that as part of our template for a new patient evaluation, and the parent is saying, nope, no snoring, no sweaty sleep, no restless sleep, then I won't refer on to sleep clinic. However, as I'm seeing that child over time, I'm remonitoring and looking for improvement in ADHD symptoms with appropriate therapy, and monitoring if anything's changing with sleep, or do I need to go back and reconsider the etiology of these behaviors that look like ADHD if they're not progressing as I would hope.
That makes sense. Yeah.
Our listeners may be wondering what's happening with Tim Farbaugh.
Yeah.
We find out he breathes loudly during sleep. He snores at times. He also has been hyperactive at school. And despite his treatment for ADHD, methylphenidate, twice per day, his mother thinks he gets possibly rebound hyperactivity in the evening before bed. She has retimed his second dose of methylphenidate to 5 p.m., hoping that it would cover him more in the evening hours. As a takeoff from that additional history, what sleep-related symptoms should parents keep an eye out for that may warrant, say, a sleep study?
So I think persistent mouth breathing is one thing that I think about. And it is tough when children are sleeping independently to even rely, like you said, on parents reporting, but snoring that can be heard out of the room, gas pauses, of course. When the parent goes in, is the child in a different position or sleeping positionally with their neck arched back or prone? Especially for genetic conditions with low tone, you'll hear that a lot. And then restless sleep, the sheets all over the place in the morning. And is the kiddo waking tired, no matter that they're getting a sufficient number of hours of sleep, would be concerns for me for sleep disordered breathing. Sometimes the child will be able to articulate having a dry mouth in the morning and needing water during the night. The restlessness and rebound hyperactivity at the end of the day, though, I think is really interesting because as an ADHD provider, I'm always thinking about the parents' observation that the kid seems like they're way hyperactive, but their baseline has changed, right? They've been on medication and they may be back to their normal level of activity, and it may not really be hyperactivity beyond what they would have been unmedicated. So that's number one. Number two, if they're not getting enough sleep, the decline of medication coverage plus fatigue and the hyperactivity that comes with their wanting to move to stay awake and alert might be why it's looking more hyperactive at that time. And then the third thing I think about, again, coming back to they've ended a school day where the structure is there, they come home, and now that it's just open time, maybe. And so without the rules and structure, the parent really may be seeing, and that may exacerbate the unregulated behavior, particularly if the parents themselves may not be so structured because of their own ADHD. So it's a little complicated for me to interpret what does that rebound hyperactivity mean. But I sometimes will use a third dose of a short-acting Ritalin in the day to cover that period. But it all is kind of balanced with the side effects of the medications.
How might you time it?
So it depends on the individual child and how significant the symptoms are. Typically, I'd be thinking about it, say, after school at 3:30 or 4 to cover that evening period. However, I've had 1 or 2 patients where giving it later, really prior to bedtime, has worked for them to settle their activity. That's been more rare and not the norm. But I've had that occur.
I have a couple of questions. So, kind of about medication too. is this someone at this point though, now that maybe he was on Ritalin twice a day and he's still kind of having symptoms at this point, would you, if he hadn't been evaluated for sleep at this point, would this be an appropriate time, to say, okay, well, maybe it's something sleep related or, sleep apnea related? Because how much is what is an appropriate dose of medication, or how much is enough? Because from a sleep standpoint, we're familiar with stimulants, but mainly in the setting of narcolepsy and idiopathic hypersomnia. So so I guess question one is, is this an appropriate time now to evaluate for sleep? Two is kind of what is an appropriate dose that's probably age specific or symptom specific. And then the third, I guess I wonder is is there a preference to stimulant versus, and methylphenidate versus dextroamphetamine versus the long acting versus Concerta versus, there's so many Vyvanse versus, I have no clue. We pretty much use Adderall or Ritalin, and then, but I usually for narcolepsy, I'll usually start with Provigil or Nuvigil. And then if those don't work, then I'll kind of go to the amphetamine. So, what's your it's a lot of questions. Sorry.
It is a lot of questions. You're going to remind me which ones I missed. So, I'm just going to step back for a second and talk about stimulant treatment for
absolutely.
ADHD.
Perfect.
So there are two main groups of medications, the dextroamphetamine and the methylphenidate group. And all the other name brands kind of drop down from there. Within each of those subsets of medication are short acting, which typically will last about 4 hours per dose, intermediate acting, which are 6 to 8 hours or so, and then long acting, which are 8 to 12 hours, depending on the medication. Almost all are oral. There is one patch methylphenidate product. So you have that array of medications one can choose from, and probably about, I'm going to get, not going to be accurate on the percent, but probably more than 70% of kids, it doesn't really matter which medication you start with. You will perceive benefit for their ADHD symptoms, no matter which of the medication groups that you start with. There are subsets that do better with one or the other, but probably 95% of kids can be treated with stimulant medication and do pretty well. So there's the array of medications, and then there's individual variability in how they respond to the medications. So some people will respond typically. They take a short acting and it'll last for 4 hours. So onset in about 30 minutes, it lasts about 4 hours. Or they'll take a long acting, onset within 45 minutes to an hour, and it'll last 8 to 10 hours. But there are subsets of individuals that are faster metabolizers and slower metabolizers. So in my practice, I've had all ranges, from kids taking a short acting that's lasted them all day till 5 p.m. and kids that are faster metabolizers who take a long acting medication at 6:30 and it's out of their system by noon and they need a second dose. And so it's really, really helpful in the management of ADHD symptoms to ask a lot of questions about what time did the medicine, what time was it given? What time did you perceive benefit? Either asking the child themselves or the observers, and then about how long did it last? And all of that will kind of help you get to the right medication regimen for that individual child. Along with that, you're asking about problems with sleep initiation, because kids on stimulant medications might have problems then getting to sleep if the long-acting medication is acting too long, or if they take a short-acting medication and it's too close to their bedtime. And so in Tim Farbaugh's case, that he probably is taking a long-acting and then has a booster of a short-acting at 4 or 5 p.m. And so one of the questions I would have for Tim Farbaugh's mother is whether she perceived any increased difficulty with him getting to sleep when she added that 4 or 5 p.m. dose of medication. Was it a help or was it a hindrance? I've forgotten all of your other questions.
Well, I had a question for you.
Yeah, that's fine. Go for it.
When we talked about perceived benefit, kids often have difficulty describing, what they're experiencing with medication. Is there anything objective you can use to see if it's working? A test we can run to see if it's working, or it's pretty much how do you feel? And what the parents say. We're asking 2 people potentially who have ADHD, what's going on, and
It's really true.
It's subjective, is what I'm getting at.
So there are available rating scales that you can use that are free, called the Vanderbilt scales, and you can get those if you just Google Vanderbilt scales, and that'll provide a parent and a teacher form, and it's validated for kids 6 to 12 years of age. But I've used it for older individuals too. And so I usually will get that or a Connors rating scale, which is a more formal scale that is age and gender normed at baseline, and then a month into treatment to sort of validate for me whether or not the observers of the child are perceiving benefit. Now, the caveat is, when are they going to do the observation? So the teachers will observe probably during the time that the medication is active. But by the time the parent gets home at 4 p.m., the medication may not be active. And so I always ask the parents to, at least during the trial phase of the medication, to do their observations on the weekend. So they're observing when the medication should be active so they can be a valid reporter. Now, these scales like Connors rating scales or others have forms for the child to fill out too, but I think you have to be trying to remember the lower age, but it might be like 13 and up, that they can report on themselves.
And does it correspond with an improvement in like schoolwork? Because a lot of these kids come to light, right, because they're not doing well in school, and ADHD is identified, and
so that's a dilemma in the care of individuals with ADHD. So the data really show that there is improvement in attention and these markers of the behavioral profile of ADHD. Unfortunately, we haven't really been able to document that there is substantial improvement in grade outcomes like years later. There is, though, improvement in the individuals like staying in school, important other markers of the individual's productivity long term.
Want to get back to Tim?
I think we should.
All right. So there have been a few nights during which Tim has woken up screaming in the middle of the night. One such episode occurred before a University of Michigan-Ohio State football game. And he recalled a bad dream about Michigan getting... I have had this dream before, okay? I'm Tim. I'm Spartacus. About Michigan getting shut out. However, the majority of these events have involved prolonged periods of screaming and crying, yeah, it's me, that he didn't remember the next morning. So I guess you had mentioned kind of at the beginning that ADHD could also be related or associated with parasomnias. So is there any counseling you would give to the parents, or is there any anything you're looking for in terms of asking them about parasomnias that would lead you to believe that this is more ADHD related versus maybe a sleep disorder?
I really think more about sleep disorders for this kind of a problem than ADHD per se, as well as I'm really wondering what's going on in that household. Aren't you? Are they like looking at like old like tapes and stuff, for the next plays and stuff like that? What's the conversation around the dinner table, as we're coming up to the game? I'm really worried about that.
Football related.
I'm thinking so. And it just makes me worried. I don't know. But the other thing, I guess, is, obstructive sleep apnea could be one of the factors that, if treated, might serve to also treat the night terrors that he's having, or if he's the restlessness that mom described at the beginning, does he have iron deficiency? And is that something that, if treated, maybe the night terrors would be better? And sleep deprivation. So sleep deprivation and illness with fever are two really common reasons for night terrors. But he's kind of in an age group where it's not that
actually,
uncommon.
So is there any specific parasomnia that's associated with ADHD? More common or no? It's kind of a broad range.
Or stimulant meds.
Yeah, I guess that was the next question. Could just the medication be causing?
That's a really good question. I think I don't know the answer to.
Okay.
Yeah.
Because I guess that's the question we always have with narcolepsy patients is, we want to get them to go to sleep or idiopathic, and then we're always cautious about giving them a stimulant and then causing them to then be awake. So it's always this: how late is too late, and how much is too much in the evening, or is the goal really to have everything out of the system by the time you get to bed, or like all the half-life, at least be completed. So,
I think what I really like about stimulant medications, rather than other second-line medications for ADHD, is that you can give them and sort of record what you see and try a different timing or a different medication or dose the next day. And just do kind of an experiment and ask particularly with adults, to just collect the data. Did they have trouble that night with a higher dose? If you're using, say, a long-acting methylphenidate, I'm trying not to use brand names, at an 18 milligram, and then you double it, does that provide better daytime coverage, but it's not inhibiting the nighttime sleep onset?
Right.
And you can do those changes really day to day because they're out of the body the next day.
What are some, you just mentioned secondary what are some secondary medications for?
So these are, I don't know data about their efficacy for narcolepsy. However, for kids who can't take stimulant medications, or the side effects like weight loss are too much, or I've had some individuals with, so hallucinations are really rare, but I've had kids who've experienced that on stimulant medications, and so they just can't take them. So alpha agonists like guanfacine and clonidine would be one group, and then a second is atomoxetine. Yeah.
Now, in terms of dose timing, there's probably not a generalizable cutoff point, right? For short-acting and long-acting meds, where you say, no, you better not take that after such and such PM.
So generally, I'll say not after about 4.
Okay.
And that's based on the short-acting lasting about 4 hours. And I'd like my kids to be in bed by 8 or 9.
Makes sense. Yep.
Yeah.
All right. So for Tim in this circumstance, would you might just reassurance to the parents on the night terror question, potential night terror question, or would you?
I would really ask more questions about what's going on at home.
The conversation.
Yes.
Yeah.
And maybe get a sleep log so I can know how much sleep is Tim really getting.
Make sure sleep deprivation is not contributing.
Right, it's not a part of it. And that's really, I think, the most common that I see in clinic, particularly for younger kids who are giving up naps. Sometimes the solution for those night terrors is putting the nap back in. But
and for a 5 to 6, how old is Tim again? 5?
He's 8.
8.
He's 8.
Right in between.
He's 8.
Come on,
Okay.
man.
I'm 3 years in the past.
Yeah.
So for 8-year-old Tim, you'd want him to get at least maybe 10 hours of sleep?
Probably, yeah.
Something like that.
Something like that.
Yeah.
Yeah.
All right.
Which he probably could get.
You probably could.
Yeah.
If we maybe cut out a football game or two.
Probably.
So when we examine Tim, he does have an overbite. He's got a crowded airway, a somewhat high-arched palate. He's restless in the clinic, doesn't appear tired, but mother tells you that he fell asleep on the car ride to the appointment, which was only a 15-minute ride. A polysomnogram is done with CO2 monitoring and a parasomnia montage. Iron studies are ordered. The polysomnogram shows sleep apnea with sleep fragmentation, frequent arousals during NREM sleep, and the iron studies, including ferritin, are normal.
What's normal?
Exactly.
That's a good question. So normal for lab normal or normal for us normal? So
Right.
we're going to say normal for us normal, which is greater than 75.
Or 50 in kids.
Yeah.
15 kids.
15 kids?
Mhm.
Yeah. Which is an interesting question because it's not a lab standard. So
It's
that
not a lab standard.
may
and
get
that's-
missed.
And that's a primary care problem.
Oh yeah. I had
Mhm.
a patient who had a ferritin of 33 and I told them they needed to start iron or iron supplementation, and I saw them back in clinic like a month later and they're like, no, my PCB said my iron is fine, and they put me on Requip.
Mm.
And I was like, no, not Requip.
Yeah, we've been through this.
Yeah, I know. So I had to get them off quickly. But
So that the NHANES data show that average ferritin for like preschoolers is in the mid 30s. And so if you check, they're probably going to look low.
Right.
However, they have symptoms, and that's the difference, right? So, but it is I get the same from some of the primary care that we.
But again, with the problem is with kids describing restless
Right.
leg
Yeah.
syndrome.
it's
I
hard
can't-
enough for adults to describe restless leg.
Yeah.
I can't imagine what it'd be
So
like for
it's like if they're just restless and the ferritin's low, do we replete it?
So that's a really hard question, I'd say, in clinic. And we oftentimes will err on the side of suspicion and treatment, but monitoring. And so we have a pretty robust lab system to monitor, so kids aren't on and on and on and on and never going off the iron. So looking for improvement in their presentation and the ease of getting to sleep. But it is tricky.
Yeah.
The kids just can't tell us.
Probably easier to err on the safe side, I guess. It's just an
a little
iron
bit of
supplement.
It's not too.
So there are some studies where they've looked at what age can kids really describe that sense reliably, and it looks like 8 is kind of the lower cutoff for kids. So we could ask Tim.
Yeah. And we might ask about pain in the legs or an uncomfortable feeling.
But like, when you start having like a stimulant on board, do those symptoms, get better or worse? Like
I haven't. I don't think they do, and I don't think I've experienced that with the kids that I see, and I see a lot with both things.
Right.
Yeah.
That question of if you have someone with ADHD who's more of the hyperactive type,
Mm-hmm.
they're moving their legs a lot. How do you differentiate
Right.
ADHD symptoms and potential restless legs symptoms?
So the treatment with iron, I perceive it as pretty innocuous.
Yeah.
At the doses that we use in kids, which is we usually are 2 to 3 mg per kilogram. Some guidelines will say 3 to 6. But as long as you're monitoring for improvement and then taking them off if it's not making a difference.
good.
So we have now, so Tim has sleep apnea. We know that sleep apnea can provoke hyperactivity. And you touched on this a bit earlier, Barb. The question of, let's say we now treat the sleep apnea somehow, and maybe we'll find out exactly how in a bit, but, and his behavior improves. Do you then start a wean of the stimulants that you've put Tim on to this point?
So that's where the rating scales and having a baseline can really help. Because I would like to make sure that Tim gets adequate treatment, but not too much treatment, because these stimulant medications, again, can have side effects of headache and poor appetite and weight loss. And so I'd like him to be on enough, but not so much.
Mm-hmm.
Yeah. So yes, I would have that discussion with the family, but I'd try to have data to really support the decision to reduce the medication.
I think a lot of parents would want to know going into treatment for the sleep apnea, like, okay, well, what can we expect for medication? Is he going to be off of this after this, whatever he gets to treat his sleep apnea? Or, because that's a question adults ask me with their blood pressure and sleep apnea. Like, well, when can I get off these blood pressure pills?
I feel like on the adult end, we get a lot of referrals for people. Like, I think people expect that treatment of sleep apnea is going to cure hypertension, cure memory loss, cure,
Right.
dementia, cure heart failure.
Yeah.
And unfortunately, it's more or less reducing the risk of more cardiovascular disease, or kind of helping to mitigate the symptoms that are already
Right.
there. And I think you had mentioned earlier that you said about 10% maybe can
In my
clinical
experience,
experience. Yeah.
Well, I thought that was for insufficient sleep. With about 10% of the kids getting adequate sleep, that would relieve it. But for treating sleep apnea, what could we tell parents, hey, to expect regarding medications?
Is it ever possible to stop stimulants?
Right. After the sleep apnea has been treated. Well, what do you encounter with this?
So I think it depends on the family and the timing. I in my practice will typically bring up every year or so, do we really need the level of medications that we're on? So I'm reevaluating anyway, because individuals kids are learning strategies, right? And so as they learn strategies, their need for medication to really, they may need the medication as less as part of their profile. But I don't have a good number for the percent of kids after getting their obstructive sleep apnea treated that can go off medication completely again. I think it's more in the realm of maybe reevaluating, can we reduce the medication need? Can we use it maybe not every day of the week, but mainly just for school, that kind of thing, and tailoring it to the individual.
The kind of getting back to what you had talked about earlier about, as kids get older, was always kind of my understanding. I'm not a pediatrician, so I don't deal a lot with ADHD. That it was kind of more of like a lifelong disease, but it seems like I've had friends and stuff that they're like, oh, I used to have ADHD, or I used to be on medication. And I feel like you see that sometimes in adult clinic too. There's like, I was on. So you had said sometimes it's just people, they just don't need the medication anymore. It's not the fact that they don't have, I guess it's a disorder. It's a symptom-based disorder. So they don't have the symptoms anymore. They don't have the diagnosis anymore.
But I would say that maybe the decision to go off medication is not always made in a really methodical way. Teenagers may decide, I don't want to take this anymore. My friends don't need this. I don't need this, and just go off the medication without really looking at target behaviors and saying whether they're worse or better. And they're going off medication at a time when they're at risk for having shorter sleep, right? Because they're coming into more of a delayed sleep phase pattern and earlier school start times. And so their sleep periods are just crunched, which then makes with their sleep deprivation, symptoms of inattention and poor organization and stuff like that more difficult. The whole question of the lifelong nature or not of ADHD is really a debate. People have tried to look at it looking forward and looking backwards, asking people as adults, did you have ADHD before? And the percent ranges, I've read 20 to 70%, whether it's lifelong or not. So it's all over the map. And then there's a newer set of literature saying that adult ADHD may be a completely different disorder and quite different than what childhood ADHD is. So I think we have a lot to learn about who still would meet criteria for ADHD, who would still need medication for ADHD in adulthood. But the period of adolescence is really, I think, high risk because people will go off kind of precipitously and then be undertreated and be failing at the time that they should be doing well in preparation for college and things like that. I don't know if that helps.
No, it
does.
Thank you.
Yeah.
Getting back to Tim. So question was, Alok said, so Tim got an adenotonsillectomy since he's 8 years old, and that's what they...
Did it work?
It did. It did work. Yes. His mother says no more night terrors. Michigan's no longer losing to Ohio State in his dreams. Restful sleep. However, he's still active at bedtime with difficulty falling asleep. He'll also, he wants to play more Madden on his PlayStation. And he says that the PlayStation or the Nintendo, whatever he has, makes him sleep after 5 to 6 games. So he needs to play 5 to 6 games, and then he can fall asleep. So I think, the sleep apnea is treated, based on a repeat sleep study. So he still seems like there's some bedtime resistance, so there's something going on in terms of him wanting to fall asleep. Is that, how often do you see that in
all the time? All the time.
And is that just him being 8, or is that ADHD, or
Or is it habits that have kind of developed over
or his
time?
parent problem of limit setting behavior from the parents?
Yeah, it can be so tricky. When parents get home after a long day and they just have this few hours with their kids, a lot of things may go kind of awry and limits aren't set. And then expectations the child has for being able to kind of just stay up and do what they're going to do. Or if the parents really are enjoying doing an activity with the kids. And so it just sort of evolves. I just am wondering how long these games are and what his real sleep onset time is.
Usually a game of Madden takes about 30 to 40 minutes.
So 5 or 6 games,
that's a long
makes
time.
it a really long time. And then when it's done, is he like ready for bed? Is he really charged up? So we think about kind of good habits at bedtime that really can facilitate better sleep onset, sort of calming strategies that would be great to be able to talk with these parents about, because I think it would really help Tim a lot. Because right now he would, from what I'm hearing about Tim, I'm really worried about like a behavioral insomnia limit setting type, which at 8, I mean, you typically these kinds of things will start in preschool years, and that it's persisting at 8 makes me a little bit worried about who's running the show at home.
Sounds like Tim is.
For those of us facing boards, can you tell us more about behavioral insomnia, limit setting type? Is there any particular key points we should know?
So people talk about curtain calls, that there's one more request and one more thing, and I just need one more hug, and then I'll finally get to bed. And that can delay bedtime. And again, it can be really tricky for working parents who that's their only time with their child, and they're exhausted and they just want to meet their child's needs and give that extra hug, not kind of realizing that the consequences of all that delay is a shorter sleep time for their child. So that behavioral resistance and curtain calls is kind of part and parcel of behavioral insomnia limit setting type. And once the limits are set and a better routine is set, that can really treat the disorder, which I can come back and talk more about. But the other piece of it is kind of combined type, because how does Tim finally get to bed? Does dad finally say, oh man, you get to bed, I'll just lay down with you to get you to sleep? And so now his sleep onset is filled with all these associations that are not just him in his room alone, but now involve and require a parent to be there. And sleep onset association type are sort of special circumstances that are needed at bedtime to get to sleep and required through the night, so that sleep onset association type is more likely to be associated with arousals during the night at normal partial awakenings that then require the parent to come and recreate everything.
Maybe lay with the child for a while, or
to get them
whatever
back
it
to
is.
sleep, or the child comes and joins them. And so I'm worried. We don't have enough information here about. You guys could have asked more questions.
We are. Well, that's
it was maybe combined time.
That's what happens when you get 3 adult physicians doing a pediatric history.
There you go.
So,
but I think these are really, really common. So behavioral problems around sleep for kids is like 10 times more than the medical problems for sleep.
How often are you doing CBTI, or is it pediatric behavioral?
So we do more sort of straightforward behavioral stuff with the younger kids that we see, and it might involve simple things like, again, asking for a sleep log so you kind of have an idea of when is the child finally going to sleep, because at 8 p.m. bedtime may be way out of line with when the child's actually going to sleep. And then setting a routine, kind of talking about the elements that you can take care of, so you can give a snack and you can give that extra hug. And that's part of the routine, so that those requests that have kind of been there and are delaying bedtime are met before they're asked for. And to set that shorter routine then right up against their readiness for sleep onset. And then once that's coupled well, then moving it back in time to your desired bedtime. But that takes some data, again, with the sleep log, some discussion with the parents about why in the short run is it okay to put them to bed an hour and a half later than their desired sleep onset time, mainly because they're up anyway. And now we're going to use the sleep log as a tool to define when they are ready to go to sleep. I think it's fun work to do, but it's a lot more straightforward behavioral work than working with a child, say with CBD.
Is there kind of follow up? Just is there a propensity towards delay in children with ADHD? Because like in some disorder, like bipolar or depression, there's a genetic there's changes that happen to like in the clock mechanism that leads to a more propensity to delay, or we know that children with autism have a higher propensity for bedtime resistance. Is there that you see in ADHD children, that it's actually more of they just are going to be delayed more?
So the data around ADHD is tricky because the data around autism and sleep suggests this delay or insomnia is much more a part of the picture. For ADHD, because we're sort of reliant on parent questionnaires and not sort of the child themselves, or the limited studies that we have using actigraphy or our PSG. The data isn't terrific, but it is suggested that for combined type ADHD, that a delayed bedtime and sort of reduced total sleep time may be more the norm.
And for someone like that, do you ever use melatonin to try to shift their clock, or use like light therapy in the morning?
So light therapy for individuals with ADHD can increase more of an morningness and actually reduce their ADHD symptoms. And there's, for adults with ADHD, sort of a suggestion of more eveningness, or more of a problem with a delay. But for kids, it's a little less a single answer. And yeah, we'll use melatonin in clinic, but again, as a tool. And that's where I think one of my frustrations can be, where parents have received a recommendation from their primary care provider to just start melatonin, but to start it without sort of the necessary questions about when is sleep onset really occurring. And so melatonin given out of line with current sleep onset time may not work very well. And so parents may perceive this as not an effective strategy when it just wasn't used correctly. But in sleep clinic, we'll use it as a tool along with these behavioral measures to create the behavior change that then can persist. But we use melatonin fairly frequently for insomnia, whether it's ADHD or not.
Okay.
It's so important to differentiate behavioral insomnia of childhood from ADHD symptoms, which some parents may misread in insomnia as, oh, it's just part of ADHD and we need a higher dose of stimulant and that kind of thing. So again, why clinics like yours are extremely beneficial to parents and children.
And I think the use of routines, I think parents forget what it was like to be a kid when routines are just so great, because you know it's very empowering to know what's going to happen next. And it's very disturbing when you just don't know what's coming next in the lead up to bedtime. And so the use of routines, I think, is a very powerful educational tool to use with parents for kids of any age.
Yep.
Yeah.
I want to jump ahead a bit and ask a question about what might be in store for this field. What would you say are some opportunities for improvement and or research of the care of children with ADHD and sleep disorders?
So they have looked a little bit at ADHD and sleep disorders by subtype. So I think that there's more work to be done in that area. We don't really have a clear enough picture about what ADHD is, I think. we have some ideas about neurotransmitter hypotheses for this disorder, but exactly how it interacts with things like sleep disorders that are so commonly affected, I think that from a neuro imaging and functional neuro imaging perspective is going to be really, really interesting. A second is this whole idea of fast and slow metabolizers. What's that about, right?
Mhm.
And does that mean that that's true for other medications that individuals, neuroactive medications that they may take that may affect sleep? Education. So we know, unfortunately, that training, giving parents, so parents who are involved with studies and are trained, and this has to do more with ADHD kinds of things, but are trained to about how to manage their child's behavior. When asked, like 6 months later, about the education they were provided for that study, don't remember it very well. And so I think that's another piece I'm kind of interested in is how can we improve the delivery of our recommendations so that they're implemented better by families, and maybe the delivery of our recommendations to our other peers who are going to be implementing them in their practices. And then I'm particularly interested in iron and its role in the brain and its role for ADHD and for sleep, and whether there's sort of a really a common mechanism there that might underlie both this restlessness that you described during the day and restlessness during sleep that might be a subtype that if we understood iron pathophysiology better, that might lead us to more robust treatments.
Andy would be interested in that, maybe.
Anecdotally, have you seen resolution of ADHD symptoms with iron treatment in your clinic?
Not entirely improvement, but not entirely.
I wanted to back up. I had a question for children. In adults, this comes up all the time about what's the proper dose of melatonin, because we see tolerance develop at certain doses, higher doses. What dose do we start kids on for melatonin?
So in our clinic, we'll usually be 1 to 3 milligrams.
Okay.
And we pretty rarely go above 6. And I'd be interested in what you guys do for adults.
So 0.5 to 3. Yeah, low dose, but it's not surprising if I see someone in the clinic and they're like, oh, I was told to take melatonin. And so they're taking like 15 milligrams.
Yeah.
Right.
And they're like, it doesn't work. I'm like, well, first of all, it's not, just like you said, the education just isn't there that, people expect to take melatonin and fall asleep half an hour later. And it's really more for getting that behavior to pull your sleep to advance your sleep rather than to kind of as a hypnotic. So
we'll use it in both ways, actually, within our population, more often as a hypnotic, but then sometimes several hours earlier at a tiny dose to kind of pull the pattern earlier, which has been really helpful. Yeah.
Yeah, I mean, when commercially, I've only seen it, the smallest dose is 3 milligrams.
Yeah, it's hard.
Well, you can get it at 1.
Yeah, but I've looked and never seen it smaller
you go to
than that.
Costco,
Yeah.
it's like, I'll do high dose time release for REM sleep behavior disorder. So starting at like 6-12 milligrams for REM sleep behavior disorder. And that seems to work pretty well and avoids having to use Klonopin, which I don't like to use.
If you have any children with REM sleep behavior disorder, we're in trouble.
Any other questions, guys?
How would I guess the question is as adults, as children become adults and the ADHD may or may not persist, what about sleep disorders as these children go on like this, if anything to comment on that? It's just, they just blend into the general population risk.
I think, again, adults with ADHD, like 50% describe a comorbid sleep disorder. So I think it travels along. I know less about what specific disorders they might present with, but when asked and in study populations, they see that.
You have any take home points for our listeners?
I think in working with children, enjoy your work because it's great. Kids are great. But to step back and take the time to ask sufficient questions about sleep and daytime behavior, and to try to tease out if they're already on medication, sort of what are the target behaviors that's improving. And to try to be pretty methodical with it, to collect data about the ADHD behaviors, data about sleep, because I think that can kind of keep you on track in terms of your treatment progression and let you know when to turn it back to the primary care provider and things like that. So I think using more data, and rather than just sort of a cloud of I think it's this kind of thing. I think data really is underrated.
All right.
Thank you.
I think we are done for today. Thank you so much, Barbara.
Thank you.
Dr. Felt, for joining us on the White Noise podcast. We will be back next month. And again, you can reach us at www.thewhitenoisepodcast.com. If you have questions, you can email us at questions@thewhitenoisepodcast.com. Don't forget to subscribe on iTunes, Google Play, Stitcher, or Spotify. Have a good month, guys.